We're gonna talk about shockwave therapy tonight, as she said. And typically, when I talk about shockwave therapy, I can't resist going back to some explanation about really what is happening with shockwaves, because I think as veterinarians, I mean, it's good to know that we can take a shockwave, we can treat a suspensory ligament, and we can stimulate healing. But I think it's good to know a little bit more about the why, particularly because there's a ton of modalities out there. And I personally flinch every time I hear, let's do therapy X. It's the same as shockwave. We can do this. It has the same outcome. And so I like veterinarians to understand why this modality is an FDA approved thing for use in humans. It's why this modality is sold to veterinarians and should be, because it truly is an effective medical device. So we have a shockwave machine, in this case, handheld probe, creates a very high energy pressure wave. And when applied to the surface of the body, we get an outcome. And this is, it's like initially, it's like you shockwave bone, we see an increased density, shockwave ligament, they heal. But really, where the application starts coming in as to, the important things as to why. So first of all, when we look at a shock wave, this is a pressure tracing of a shock wave. It can go from atmospheric pressure up to 1,000 times over atmospheric pressure, back down to a tensile or negative pressure wave, then back to baseline within a few microseconds. Okay, it's a very high energy pressure wave and a very shallow, very quick acting front. Just for comparison, to be your diagnostic ultrasound bouncing along here. The old radio pressure wave units, which are really not used much in veterinary medicine anymore here. So it's a very precise pressure wave. And that's to meet the definition of a shock wave, it has to have these parameters: very rapid rise, high energy, and tensile force. So that tracing defines what a shock wave actually is. So back again, pressure wave applied, shock wave applied, goes through the tissues. Something happens to cells to get this outcome. Okay. So how do you shock wave something and then get an outcome that we're desiring? And that occurs by an effect called mechanotransduction. And that sounds, really complicated or a lot going on there. But actually, it makes a great deal of sense. Mechanotransduction is simply the process in which physical stimuli create a biologic change or a cellular change. We can look at simple things like, hairs in your inner ear. That's mechanotransduction. That's how you maintain balance. It makes sense to us that bone remodeling, as you load bone more, it is stimulated through the load, through the compressive and tensile forces to remodel to meet the needs of the bone. A lot of things are very well understood about mechanotransduction, how shear stress on the surface, how actually changes in the nucleus can occur, a long list of biologic components that act as mechanosensors. So stretch activated ion channels, you can stretch cells, fluid shear across the surface, simple cell-to-cell junctions. The cell nucleus can actually respond to deformations of the cell. And then down at the bottom, compression of the intercellular space. So it's actually almost like a population thing. When cells are squeezed together, there's mechanotransduction occurring. So we can take something like a very high energy pressure wave, a shock wave, and apply it to the cells and actually trick them into a healing mode utilizing that pressure wave. The shock wave is very unique in that you have the very high energy, high pressure. you have the tensile pressure, tensile forces, all within a very short period of time. And this also creates a shear stress. So we can get the compression, the tension, and the shear all from a shock wave. So we can maximize what's actually happening in the cells. So we know that we can take the shock wave. We know that we can get this outcome of mechanotransduction that's desired. And more recently, what's being well understood is the pathways in which these occur. And I'm not going to go through a bunch of biologic pathways because as veterinarians, probably not was, biochem, et cetera, probably not our favorite classes. But just going to give you one example here. TLR3 receptors, they are in the body, and the objective is typically to generate an angiogenic or a vascular growth response. It's part of the immune response. It's part of the inflammatory pathways, and it's needed for neovascularization or an angiogenic response. So no TLR3 pathway, no angiogenic or healing response utilizing neovascularization. And so Dr. Hansfeld's study here points out very well, and I'll explain the model. What it actually is, it's a rodent ischemia model. So they ligate one of the femoral arteries, and then they look at the amount of ischemia that occurs, or the opposite is they look at the amount of perfusion that's occurring. So we're looking at that both ways here. So in these mice, there's a femoral artery that's ligated. And if you look at limb tissue perfusion from the time it's ligated out through 28 days, the limbs that were shock waved had a significantly greater limb perfusion than those that were not shock waved. And they also had a group of mice that are TLR3 knockout or no TLR3 pathway available. And you can see that the no TLR3 pathway have minimal perfusion at day 28 compared to baseline, significantly less than the shockwave treated ones. And the control treated ones that are basically not the TLR3 knockout, but not shockwave, at 28 days was similar to the TLR3 devoid mice. So very interesting. And then the opposite way is how much limb necrosis occurs. The shockwave treated ones were significantly less than the controls or the TLR3 knockouts. So that verifies that this pathway is an important pathway that shockwaves utilize to get this angiogenic response or healing response that we would like to see. This is just a cool picture of the same thing. So red is normal perfusion. The normal mice that were not shockwaved, we see very little red in that limb here compared to the shockwave treated ones where we have good perfusion. And the TLR3 knockout mice are very consistently poor perfusion. So that's just one pathway that's been documented as important in shockwave therapy. And one of the reasons I point this out is I think with time, we will see more pathways evolve, as well as potentially evaluating those pathways, using those pathways as a mechanism to determine the best pressure waves and how best to apply our treatments. So it's just given us one more tool to dig down into these things. Like I said, there's a number of paths that have been identified. I just documented some of those here. And this is really where kind of current research is on looking at shockwave therapy, the paths that are stimulated in the mechanotransduction to get the ultimate outcomes that we're looking for. So I can't help but step back and kind of push a little bit of science out there as we go, but that's kind of where a lot of the current research is. So when we shockwave, then we have these signaling pathways that I just shared one with you, and then we get outcomes ranging from control of inflammation to the angiogenesis we just talked about, stimulation of growth factor production. And so I'm going to use another good example here. I like this example. This is a example of Dr. Shu that shared with me, looking at ischemia in the left ventricle following a left ventricle ischemia model. So I think this stuff's a little neat, it's a little different than what we look at every day, but it helps us understand what we're doing. This particular model is designed to mimic coronary artery disease. And it's really cool from the standpoint, it's designed to really mimic the slow formation of a plaque in a coronary artery. And so this is common, atherosclerosis, something that's routinely seen in humans. It's not what we deal with in horses, obviously, or even dogs. But it's a good example of what we can do with shockwave therapy. So in this model, they use an amyloid constrictor, which is a device that's a stainless steel ring with casein within it. And it's looped around the artery that's being evaluated to create the ischemia. And then after surgery, that the casein within the constrictor takes in fluid slowly, and it slowly constricts the artery. So it a lot more closely mimics a heart attack or atherosclerosis than it would by just ligating an artery. So a slow ligation of the artery creates ischemia in the ventricular muscle. And subsequently, then you can see the decreased blood flow as the amyloid constrictor restricts the coronary artery. And then that leads to an ischemia. And then these hearts are ultimately shockwave. And so that's very complicated. Well, it's not complicated to the engineers, but shockwaves are applied immediately after the P wave, the QRST, the ventricular depolarization, so that it does not stimulate a muscular contraction. So it occurs when the muscle is depolarized. The shockwave machines that are utilized for cardiac use are linked to an ECG, and they fire right after depolarization. So in these, there's naturally occurring progenitor cells that are within normal cardiac muscle. Then cardiac muscle that's ischemia, you will see more of these labeled CXCR4 cells, surface markered cells. And so in the ischemic myocardium, we have some of these progenitor cells showing up. In the ischemic myocardium that has been shockwaved, there is significantly more of these progenitor cells occurring. Similarly, just another surface marker, very same outcome. Normal myocardium, ischemic myocardium that's shockwaved. So the shockwave therapy is stimulating the homing of these progenitor cells within the body. So another objective we have is to, a lot of cases, recruit naturally occurring progenitor cells. And the shockwave therapy in this case, in this myocardium, it's being very effective doing that. So the shockwave therapy, in my opinion, kind of drops into my list of regenerative therapy. I think in equine medicine, there's a ton of these things we can use now. We're very fortunate in this. We're in this regenerative therapy mode. We can look a lot more about healing than palliative therapy that we have in the past, particularly when we're talking about joints. But how do we blend these together? And that's an ongoing question. Probably not going to completely answer, but I'm going to throw a few things out tonight. First of all, as veterinarians, what are we doing with shockwave therapy? And I pulled this particular image out here for one reason. And I think over time, it's really boiled down that we're using focused shockwave therapy heavily for tendon and ligament injuries, probably a little less. I was a little surprised that muscle pain is quite this high. Osteoarthritis and navicular is much less common, but the tendon and ligament issues are in general the most common applications for us on the equine side of things. And veterinarians report it to be highly effective when dealing with ligament injuries and osteoarthritis. So how did we get to there? And I'm just going to pull out a few things. This is a study that was out in the last couple of years out of the Purdue group, looking at treating shock waving, proximal suspensories, and superficial digital flexor tendons. The objective of this particular study that was published is looking at how many treatments were done, greater 3 or more treatments or less than 3, and then compare the outcomes between groups. And I think this was a good study for a couple of reasons. When we first started shockwaving horses, I was at Purdue when we got the first shockwave quite a few years ago now, and we were learning how to use it. And it was the second shockwave in the United States. We didn't really know what we were doing. We had some information from the human side, a little bit of information research-wise, benchtop type research. And we knew a really good application was proximal suspensory disease. And I still go back and I can still see this horse in my head that had a chronic rear limb suspensory that I'd been treating for most of a year and was getting frustrated with. And we got this shockwave machine, brought it into the hospital. At that point, we were anesthetizing everything to treat it with the equipment we had. We anesthetized this horse. I shockwaved it, sent it home, brought it back a month later, and there was significant healing that we had not been able to get in the last year. I'm like, okay, great, we're golden here. I sent it back home, brought it back a month later, and it looked just like it had after the first month. So I was like a little dejected there, but we had some improvement. I kicked it down the road for another month, looked at it, and we were still stalled out there. So we treated it again, and lo and behold, it got better again. Continued to improve. That's when we're like, wow, okay, we're probably going to need to do a series of treatments. And then over time, that kind of evolved with cases and looking at things. A lot of cases were treated 3 times at about 3 to 4 week intervals. And that was kind of how the treatment protocol came about. But we never really sat down and looked at this data. And the group at Purdue has come back and done a nice job of this. And they found that horses responded better in the short term with more treatments. 3 or more treatments really helped these horses move along in the short term. In the long term, didn't really matter too much if you did 1 or 2 versus 3, but the more treatments, the quicker they healed. And the more chronic they were, the more poor the outcome was. And that all kind of makes sense. But 3 or more treatments will really help stimulate and move the healing on a little quicker. And that's consistent with their data. 17% sound at 3 months compared to 7.4% when they are treated 3 or more times. And then over time, the groups kind of condense together. So stimulate healing quicker, the shockwave therapy is definitely a viable tool to get that done. So then I talked about shockwave and some of the other biologics. Josh Donnell, Frisbee, the guys at Colorado State and Sports Medicine Group looked at a large number of horses, and these were kind of striated, and there's a lot of data here. The ultrasound scores from 0 to 2. This was the best ultrasound score, so to speak. These were the biggest lesions that were treated with PRP. And then the same ones, the least to the worst lesion, treated with the shockwave therapy. A lot of data here, and you can kind of see, though, how from baseline to 6 months, the groups all responded fairly nicely to either PRP or shockwave therapy. when you look at the difference in lameness or the improvement, again, shockwave therapy, these horses improve pretty consistently, very similar to the PRP, to 6 months, kind of leveled out at the 6-month mark. And ultimately the study showed that the shockwave treated horses responded faster than the PRP treated horses, which in those graphs where there's a lot of data, it was kind of hard to pick that out, but they responded faster. The less severely affected horse responded better to the shockwave, and the more severely affected horses responded a little bit better to the PRP at 1 year out. So, as equine practitioners, then typically we say, well, why not do both? And makes a great deal of sense. Why not do both? And one thing that I'll show you is why we may really want to consider it here is that PRP, and this came out of Georgia, Dr. Jaguar's group, and actually Dr. Seabaugh did this study. And what they found, the positive control with the PRP created the highest concentration of the growth factors, which makes sense. It's a freeze-thaw degranulation. However, if you shockwave the PRP, you have a significant increase in the growth factors compared to the non-shockwave group. Excuse me. So shockwaving the platelet-rich plasma improved or increased the concentration of the growth factors that they looked at in this particular study. So that would make a great deal of sense then if you're going to treat a high suspensory, to go ahead and treat them with the shockwave therapy and subsequently follow that, treat them with the PRP and then subsequently follow that with the shockwave therapy, like 3 treatments of shockwave therapy. And you're probably going to be maximizing, the best you can do therapeutically with those techniques. At this point, there is not a study utilizing a combination of PRP and shockwave therapy. All we can really do is just kind of piece those together, but it makes sense. Going back to a little bit of older data, in shockwaving forelimb suspensory ligaments, this was a study that we did using the collagenase model. But again, what we found was the lesion with shockwave therapy decreased faster with treatment out through the 84 days that were in this study compared to the controls. The fiber alignment scores were better. The echogenicity was better. So the shockwave treated horses healed faster. And the reason I put this particular slide in today was, we've talked about the whys. What is the biologic response? Well, if you look in the treated suspensory ligaments, you look at all of these fibroblasts that were recruited into this area. So the fibroblasts that were there, or the recruitment of progenitor cells, which was not evaluated in this particular study, we have a much improved cellular response in the shockwave treated suspensory ligaments compared to the untreated controls. It was very consistent throughout the legs. So very interesting. And as we learn more, now we know the mechanism or some of the potential mechanism by which that occurred. But the shockwave improved the rate of healing and resulted in the stimulation of fibroblasts. So we just kind of keep adding these pieces of the puzzle together, and veterinarians are very consistently utilizing shockwave therapy for these tendon and ligament injuries. So I'm going to kind of change paths here a little bit. I'll tell you right up front, back when the discussions about shockwaving lungs and pulmonary hemorrhage, I was the one dragging my toes. I was just really not seeing this, as a really good indication. Ultimately, Dr. Whitaker dug into this and has given us some really good information. Dr. Marty Allen really was kind of the leader on this, treating a bunch of standardbreds. There was always a little bit of concern about how the shockwave therapy would actually affect the lungs. If it was potentially negative, it would all be positive, or what would actually occur. Marty Allen kind of took the lead. One of the concerns about the safety of shockwaving lungs was, would there be potential damage at the pleural surface? Because when shockwaves hit an air interface, they're going to be reflected, and there was concern about damage at the pleural interface. And subsequently, in an unpublished study that was done at the University of Cordova, they did not see anything wrong with that. And at this point in time, in this paper that I'm sharing with you here, Bo had 40 horses treated. My guess in we're probably into the thousands now with what everyone is treated in shockwaving without any significant negative effects. So the concern about the lung safety is gone, in my opinion, at this point. But how could shockwave actually change exercise-induced pulmonary hemorrhage? EIPH occurs as a result of the shear stress, the very high pressure within the vasculature, and the big pressure changes, the positive, negative pressure changes as the horse is breathing in and out, as the abdominal viscera bounces off of the diaphragm, creates major pressure changes in very short periods of time. Blood volume, maybe we can change that some with furosemide, but how can we change, pressure within the airways? Obviously, airway constriction can make big negative pressures, but in lieu of that, and in a lot of our cases, the lower airway is probably our biggest issue. And how can we stimulate or improve airflow and decrease the negative pressure in the lower airway? And we'll come back to those comments in a minute. But the inclusion criteria for Bo's study, they had to make a barrel run in the last 2 days. They had to exhibit something consistent with either epistaxis or coughing or something that led them to believe that there was an epistaxis event or an exercise-induced pulmonary hemorrhage event. If they ran on Lasix when they bled, they had to run on Lasix the next time they were evaluated. They can't start Lasix after the first one, and they had to do another competitive run in 2 to 4 weeks after they were shockwaved, and they had to return to the hospital within 2 days for a follow-up. The parameters that were looked at was obviously endoscopy to make sure the upper airway was normal, scoring mucus, blood, etc. in the trachea and upper airway. Lungs were ultrasounded, looking at pleural thickness, and a BAL was done. All of the BALs were submitted to Dr. Coutil's group at Purdue for scoring, so it was all done blinded. So Dr. Whitaker has before and after BALs on all these horses that were shockwaved. Visual analog scale of the BAL was done to score them. Makes sense. 0, clear through frank hemorrhage at 4. The treatment protocol is pretty straightforward. I think it's available a few places, about 750 shocks with the 80 Trode at the higher energy setting. The lung fields are marked out by ultrasound, basically ultrasound all the intercostal spaces, mark the dorsal and ventral aspects of the lung field, and then the 750 pulses are spread out over that lung field. Most horses are simply treated. This study was done in Texas. So shorter hair, everything was done with alcohol and ultrasound gel. No need to clip them for this particular study. And the quick summary of everything here is 42 horses were screened, 21 met the inclusion criteria, and 13 exhibited epistaxis in the initial race, and 9 competed on Lasix. So the 21 horses were enrolled. No animal showed an increase in the BAL red blood cell after treatment, and the BAL score was improved by 1.5 grades. So the shockwave therapy appeared to significantly improve the BAL results when they came back for the subsequent BAL after the next run. So that was pretty impressive to me. The other thing, 16 of the 21 horses improved at least one grade on the red blood cell score, so fewer red blood cells. So very interesting outcome here in this preliminary study. And then where I come back to is how can that occur? What's actually happening here? And when Bo digs into this deeper, what he found was all the horses that were initially met inclusion criteria had neutrophil counts to be consistent with neutrophilic asthma. So the lower airway inflammation in this population was probably a major contributor to the initial hemorrhage because of blockage or limit airflow in the lower airways. Those horses that responded to the shockwave therapy, 63% of the responders had a 6% or greater improvement, or I guess another way to say it, a 6% or greater decrease in neutrophils within the secondary BAL. So how can that occur? Is there some anti-inflammatory mechanism occurring here? And that is distinctly possible when you start digging around. There's a number of studies in the literature that show that shockwave therapy actually decreases some of the markers, some of the inflammation biomarkers, whether we're talking about wounds, it's just simply measuring biomarkers. It actually decreased inflammation in joints in the osteochondral fragment model. So there may be some anti-inflammatory mechanism by which we're decreasing the lower airway inflammation. So I think there's a lot more to come on this particular subject. It's just that we're at the very infancy of this, in my opinion. But I will admit right up front that I think responses are ultimately in the long run going to be better than anything I ever expected. And I've seen some cases that I've struggled with that we've seen improvements. So something else to consider in your armamentarium, or in what you're going to utilize your shockwave therapy for. I really thought that there would be some change in pleural thickening if we saw a response, but there was no change in pleural thickening between the pleural grades and the outcome response. So we're probably really looking at more of an anti-inflammatory effect. This is a paper that was published a year or so ago in EVJ. Sherry is the lead on this. Dr. Frisbee, myself, Angie, and Rod all contributed to this publication. And it is an open access article. You can hop online and download this. It's a really nice, I shouldn't say that, but because I was contributed to it, but it's a really good review of shockwave therapy up to date. And it is free because Zoometica paid for the open access on it. So if you want to dig a little bit more into shockwave therapy, it's a really good condensation of the data up and through last year, I believe. So I also very aware the title was shockwave therapy in equine applications. But I'm going to take a little bit of a left turn here and look at a couple things that interest me on the canine applications. And I am an equine surgeon. I am an equine sports medicine person. I do not typically work on dogs. So these are things that we've seen in the literature, a number of potential applications for the mixed animal people out there. And there are some really good data published at this point in time. Going back 10 years ago, an AHA journal article showing very positive response in dogs with shoulder lameness. Up to more recently, actually, I'm not sure, double check the date on that. Is that really 2015? That's been a while longer than I thought. In a TPLO study at a CSU, they showed that shockwave treated TPLOs healed faster. Right on down to clear back to 2002, we published some initial experience. And the reasons I put these in is the small animal people were, no offense to anybody, a little slower on incorporating shockwave therapy, but in the more recent time, they've really turned up the application and the desire to use shockwave in these dogs. And just a good example here, TPLO dog, 6-week post-operative in the controls or sham treated. You can very clearly see the osteotomy compared to the shockwave treated where the osteotomy is more healed. And their data was very consistent. Shockwave treated dogs loaded the limb more, had a higher peak vertical force, had a higher vertical impulse, and that matched the radiograph scores that they healed faster. So kind of one of the things that kind of made me kind of turn towards the dogs here. This particular segment of video, I will admit, is one that I downloaded online because I wasn't smart enough to take video of a dog before we treated him. But this is a dog, we shockwaved a dog with gracilis fibrosis, and it was a nice police dog. And there are good data showing in the small animal side that treating fibrotic myopathy in the dog, whether it be gracilis, semitendinosus, semimembranosus, is a very effective treatment. The time from initial diagnosis in these dogs, the shockwave treated dogs remained in use 32 months compared to just barely a year in the untreated dogs. So particularly in these performance dogs, police dogs, other working dogs, that is a huge career expansion for those dogs. So those of you in the small animal side may want to kind of cross over and look at a little bit of that. And we have a mechanism to treat these dogs under no or very minimal sedation at this point in time. There was a trode developed. It's more of an unfocused trode that allows us, I don't treat many dogs, but allows you to get more pulses in the dog without sedation, a higher treatment energy without sedation, are the big things. Noise was a factor. It's clearly not the sole factor, but the less noise also improved the response of the dogs to the treatment. It didn't improve the response, it improved the acceptance of the dogs to the treatment. This particular trode, this is in general, I didn't really go into this at the start, but your shock waves come to more of a focal point. That's why they're high energy focused shock waves. This particular trode is more of a defocused trode, so it results in a little less reactivity of the patient, takes some of the sting out of the patient, but still allows for some significant improvement, particularly in these fibrotic myopathy dogs. It may not be your first choice in some non-unions and things, but it's definitely more accepted in these dogs. And so again, I try to take some of the things that we see clinically and some of the basic research and kind of put them together and say, does this just make sense? And one study, it's kind of an interesting study. They basically put a plate in these rodents between the femur and the tibia to basically prevent the stifle from bending or moving. And then they did a series of shockwave treatments. And they found that shockwaving these joints that were limited so they could not move resulted or helped counteract the fibrosis, decrease the amount of fibrosis, decrease some of the cellular infiltration, and ultimately improve the range of motion when the plates were removed. So it may help improve some joint contracture. Again, maybe a little less of an issue for us on the equine side, but a much bigger issue, particularly in the small animal side, post-operative in some of these cases. So clinically, improve these dogs with fibrosis. Research-wise, there's supporting evidence there. And this particular dog, I did get some video of him the other day. This dog, if you watch him run, he does have a touch of fibrosis still visible. but this dog is still very active, very working. And the bad guys in Boone County seem to run into him fairly often. So pretty cool application of shockwave therapy. So that's really what I wanted to do tonight. We did some horse, threw in some model stuff, a little bit of dog stuff. And we are pretty much, I might be a couple minutes ahead of time. But I think we're at a point now where any questions or discussion you'd like to have would be a good time. I actually am going to comment one thing. There's a lot of times I'm asked about treating horses with fibrotic myopathy and shockwave therapy. And I think I don't want to mislead the group in how these dogs will respond compared to a horse. When we're dealing with a gracilis muscle or a semitendinosus muscle in a dog, particularly in those, a lot of times very limited experience. So small animal practitioners, forgive me, but you can palpate, you can tell where they're fibrotic, and it's a fairly small region. Whereas when we're dealing with these in a horse, they tend to be very huge lesion, a lot of times with a lot of mineralization, dystrophic mineralization. So people have just not seen the response in horses that you can get from a dog with fibrotic myopathy. So I do want to caution this a little bit. I wouldn't just draw a line from A to B on that particular subject. I want to just put in that caveat at that point. So